What's up, Des Moines? Doc Ladd here with the Fit Moines podcast, where we sit down with the people helping Iowans feel better, move better, and perform better. Today's guest is Dr. Christopher Dickinson, board eligible orthopedic surgeon at DMOS Orthopedic Centers, specializing in hip and knee replacement, adult reconstruction, sports injuries, regenerative medicine, and workers' compensation care. A Des Moines native, Dr. Dickinson earned his medical degree from Des Moines University, completed his residency at Michigan State University, McLaren Greater Lansing, and went on to complete a fellowship in adult reconstruction and hip and knee replacement at Indiana University. His practice is centered on helping patients understand all of their treatment options and getting them back to the activities they love. If you've ever wondered whether your knee pain is bad enough for a replacement, if hip replacement recovery is really as easy as people say, or how surgeons decide when it's time to move from conservative treatment to surgery, you're going to get a lot out of this conversation. Dr. Dickinson, welcome.
Thanks for having me. Appreciate being here. So
Yeah,
look forward to this.
absolutely. Yeah, I'm really excited to have you on. This is our first time talking in person, but I've heard a lot of great things from some patients, and so it's great to have you here to talk to you.
Well, it's
So.
good. I know I have some patients out there that are saying some good things. So
Nothing but great things said for sure. So let's jump into it here. First off, what made you choose orthopedic surgery when you knew the training would consume the better part of a decade?
yeah, I mean, it's a good question. I was always interested in kind of science and medicine. And then as I kind of continued to go down that path, I was always somewhat of an athlete, or tried to be at least. I swam in college. And
Okay.
it just there's just seems like there's a lot of overlap between sports and orthopedics. And as I kind of went further down the medicine science path, I just gravitated towards ortho because to me, orthopedics is something that we see a tangible difference very quickly with people that we work with. More credit to like a lot of our internal medicine doctors that are out there trying to combat like chronic disease, which is really hard.
Yeah.
But like, for example, when we have patients come in with knee pain or like a bad knee and you can do a joint replacement and, a couple months of recovery and they're back to doing everything they want to do. It's the tangible difference that makes a huge difference, I think, at least for me, just seeing my patients happy and back to doing the things they want to do. That's kind of what brought me into it.
Yeah, absolutely. That's similar to physical therapy. I think for me, you're just able to, and we work with patients, especially our post-ops for an extended period of time. And so you get to see them, from day one when they can barely move and see that progression over the couple months and get them back. It's amazing. So
Yeah, it's really fun to see. It's just as they progress through the recovery and then ultimately get back to doing the things they love, what they weren't really doing as well as they wanted to before. Anything from, I have patients, biking 15, 20 miles at a time, going on things like RAGBRAI, doing triathlons.
yeah.
Then I also have patients that just wanted to get back to playing with their grandkids just outside and being able to get down on the ground and,
Yeah.
do that type of thing.
Yeah. Yeah. And a lot of times they don't think they're going to get back to those things too. And so it's really cool to see that.
Correct.
Reach their goals. So.
I tell most people these days, you can get back to doing whatever you feel like you're able to. I say maybe don't go run marathons with a joint replacement, but you certainly can do, pretty much anything else. These implants are lasting a lot longer and we see people that are doing a lot better with them now than we used to.
Sure, absolutely. I'm sure we'll get a little bit more into that. One thing I wanted to talk about though, as I read your intro, I said you're board eligible and not board certified.
Correct.
So take us through the board certification process. How hard is that? And really, why should patients care whether the surgeon is board certified or not?
Yeah, absolutely. So the whole process really starts, it's two-phase. The whole process for board certification starts in your fourth or fifth year of residency. You kind of take like a multiple choice type test that basically covers all areas within orthopedics, so all the subspecialty areas. And then it's basically pass fail. And that's kind of the easy part. Then you do a fellowship or whatever, go out into practice and you start practice. And then you have 5 years to complete it from when you start, but most people try and do it towards the earlier half of practice. So you have to collect a case log of about 6 months worth of all your cases and submit those. And then those go up for review. And then they select about 12 of your cases to review. And then you have to basically defend your decisions that you made, why you did or didn't do something. You're, developing the diagnosis, what you did to plan for the surgery and all of that. And then how you manage any complications that happen. Because inevitably, in any type of surgery, there's always going to be some complications, unfortunately. And that's kind of the stuff
Sure.
that they want to make sure we're able to manage on our own. So,
Sure. Yeah.
I think it matters quite a bit being board certified. It's just it it just you've basically gone through the entire process. There are a lot of hoops to jump through this training. It's kind of like the final hoop, and I think it just helps patients know that if they're going to see somebody that's board certified, that they've kind of been through the rigors of everything, and they've been tested, and they've had to defend all their decisions, and so they're probably making good decisions and helping patients get back to doing the things they want to do.
Yeah. Now, this is more for my own knowledge, but do you have to renew that every couple years or?
You do, yeah. If I think it's every 10 years, it's a little bit
Okay.
different. There are a couple different
Yeah.
ways you can do it. It's certainly not renewing it is not as much as like getting it done the first time. It's not like they go back and look at all your cases again or anything. It's usually kind of like it's more of like a kind of a you can think of it as like CME or continuing medical education type stuff.
Right.
I think you
Yeah.
might have to take a test or you review some stuff. I've talked to some of my older partners who had to renew, and they had to go back and, for example, one of my partners who does hip and knee replacement, he had to answer questions about like hand surgery. He's like, I haven't thought about this in 20 years. So
Yeah.
so the process to renew isn't so bad, but you do have to renew it.
Sure, sure. Yeah, I was just curious, when I think for my board certification, the year before I took the exam, and they completely changed it. It used to be for physical therapy, you'd get board certified and you were just board certified. So you never
Hmm.
had to renew. And then I go to take it and they completely change it. And it's more in line with what, yours is. I think every 3 years we have to submit, so many cases and CMEs. There's different things you
Yeah,
can submit every 3 years. And then on that 10th year, then you finally have to, I think you take an exam, but I think it's half of what the original one was, and you submit everything. And so, yeah,
yeah,
not quite there yet, but
yeah, yeah. It's a process. Yeah.
yeah. So looking back here, what would you say is the hardest lesson residency or fellowship taught you that medical school never could?
I think it's dealing with the patients with complications that's the hardest
Okay.
part. And that is
Yeah.
something, even as a resident, fortunately they don't happen that often in orthopedics, especially for, something like I do, but they certainly do. And I saw my attendings in residency have to deal with that and talk to patients. And, there are a variety of reasons why things happen. Some of it's out of our control sometimes, some of was in our control. But just walking through the patients and staying with them the entire way and getting them through those complications was something I watched them do, my attendings. And then I didn't realize how difficult that was until I started
Yeah.
practice.
Sure.
Just being accountable, being responsible. I mean, you have someone in front of you who's going through a really tough time, and being able to help get them through that is extremely important.
Right.
And that was part of the reason I wanted to do a fellowship in hip and knee replacement, to learn how to do like complex hip and knee revision surgery, just because anything that ever happened to any of my patients that I did a hip or knee replacement on, I wanted to be able to manage that. And then I also wanted to be able to manage, anything that came in from around the state, really.
Yeah, absolutely. I mean, you're dealing with people's lives, right? And their ability to function, in society, and that's a big deal.
Yeah.
So,
I mean, if someone loses their ability to function or function well, it's very difficult time for them. And it's, difficult to get them back on their feet and doing the things that they'd like to be doing, just having a normal life, just their activities of daily living. It's amazing how sometimes that some things can go so wrong, but we can usually get people back to functioning decently after
yeah,
problems do happen.
sure, sure. Was there ever a surgery early in your career that humbled you?
There have probably been a couple, maybe. Some of the bigger complex revision cases that I've done, like I said, I kind of see stuff from all over the state that gets sent in or referred to us. Usually it's people that have had a first time hip or knee replacement that something didn't work out or something happened or they developed an infection. Those are pretty humbling cases, I think, because I didn't appreciate at first how much the follow-up would weigh on me. And just like when you care so much and you see these people, every couple weeks, and like it's just a slow process of them getting better, you're like, I want them better
Yeah,
faster.
right.
So for like, when you do a first time hip or knee replacement, those people are doing great, like pretty much right out the door. But when we do these complex revision surgeries, I think it takes them a lot longer to get back to normal, and it's just a long process. So it's humbling because it just basically takes time, and you feel like you should have done something differently, maybe, but it's not always the case. It just takes time.
Right.
So
Now, I know ortho trauma is kind of its own subspecialty, but Is with your reconstruction background, do you ever see any of those, ortho trauma takes care of 'em, gets them stabilized, gets some function in, but then do you ever step in to kinda revise a joint or
Yeah, absolutely. So I work pretty closely with some of my trauma partners sometimes. Somebody will have an accident and break their femur or their pelvis or their acetabulum, and they'll come in with a bad injury, and those guys will typically fix it and get them back to functioning. But oftentimes, they'll develop what we call like post-traumatic osteoarthritis or, post-traumatic arthritis. So basically, because the joint had a significant injury to it, they just develop arthritis a lot sooner and faster than they otherwise would have. And so I work with the trauma guys. They'll do all the plating and the screws and everything, and then often take those out once everything's healed up, so we can basically replace their joint to give them a functioning joint without arthritis.
Sure.
So
Okay. Yeah, that
and
makes
then
sense.
and then oftentimes too, sometimes when people already have a joint replacement and then they have an accident where they break the bone around it or something that requires a revision of the joint, which I do a fair amount of, and I work with my traumatologists as well, help out with that.
Yeah. Okay. Let's shift here. Let's talk about some misconception. So
Mhm.
what's something almost every patient believes about arthritis that's completely wrong?
I think in this day and age with everything out there, I think there's some thought that people think that if they develop a little arthritis, they might not never ever need anything like any treatment, or that
Sure.
it'll just stay, they'll develop a little arthritis, but it won't get worse.
Yeah.
Oftentimes, people will come in, we'll give them like a cortisone injection. And I always have to tell people, like, this isn't going to treat the arthritis. We're just kind of almost delaying the inevitable. You might not ever need a joint replacement, but the arthritis will certainly get worse over time. It's just a matter of how bad it gets. And if it gets bad enough to a point that it's affecting your quality of life enough that our conservative treatments are not helping. And then we get to the point of discussing joint replacement. That's kind of a misconception sometimes, that I think patients think we're treating their arthritis with our conservative treatment. I think we're just trying to
Right.
manage it,
Sure.
and hope it doesn't get to the point that you need surgery. But if it does, we have good options.
Right.
So
Yeah, and I try and tell people that too, when they come in here and they're like, "Can it be fixed?" And it's like, "Well, I'm not gonna fix it. Once that arthritis
y-
is there, I can't get rid of it,
yeah,
but through
and
exercise, there's things we can do."
absolutely. And I think this is an important point, that like the role you guys fill as a physical therapist. I get patients in all the time that are like, well, I have a bad knee. I have a lot of arthritis in my knee. I shouldn't go out and walk. I shouldn't do things like I normally would, because that's going to make it worse. I'm like, I mean, yes, the joint is going to continue to wear out either way. But honestly, I always tell my patients, motion is lotion. And the more you're able to maintain motion and strength, the less likely you're going to need anything anytime soon, probably. I mean, I've seen some really bad knees before that like a lot of arthritis in them. They're like almost bone on bone. The cartilage is completely worn down, but they're pretty active people. And I think they're able to continue doing what they do because they stay active and they keep motion to the joints, and they just don't allow them to get stiff. Because I think once you get the bad joints start to get stiff, then people really start to have problems and more pain.
Yep. Yep. What would you say causes people to wait too long before getting a joint replacement?
I think oftentimes it's just the hesitation that I think people know that as they're developing more pain, that what the answer is probably going to be when they come into clinic. And I think they're a little hesitant to have any type of surgery, which is understandable. But I don't
Well,
know.
you probably hear this all the time too, where I see people after surgery and they're like, "Oh my gosh, I feel so much better. I should have done that a long time ago."
Yeah,
So
and
it's like people are
honestly,
scared to do it. It's a big surgery, but
it is,
yeah,
and it's becoming much more commonplace now. I mean, we're doing so many more joint replacements than we used to, that I think it's become more mainstream essentially. And so people, and almost everybody that comes in now has had a family member, a parent, a friend that has had a hip or knee replacement. And so they've seen a
yeah,
little bit of it.
sure,
But I still think people are a little nervous that, we're just going to jump right to say, oh, you need surgery. It's not always the case. We always try and manage things conservatively first. But you're right. We do see a lot of people that finally come in. Their joints been looks awful. It's probably been awful for a while. They've just been
yeah,
struggling to deal with the pain, and we finally do replace their joint. Like, I waited too long.
yeah, yeah,
Honestly, though, those are some of the happier patients I've seen, because I think they've been struggling with it for so long that they notice a difference
yeah.
much quicker.
That's true. Yeah,
So I tell you, I always tell them, I waited or they tell me they waited too long. I said, that might be the case, but you're going to notice a difference much quicker. You're going to appreciate this a little bit more, at least sooner.
Sure. Yeah. Well, that was kind of
So
my
you've
next
been
question too. On the flip side of that, what causes people to have surgery too early?
Yeah, I think, unfortunately, there are some people that will have joints that are starting to wear out a little bit. They'll come in and we'll try pretty much all of our conservative treatment. Most of the time, that's going to give them some relief. The injections, like I said, they're temporary. Ideally, they'll give you some relief, but inevitably, they're not going to work forever. There are people I see every now and then that continue to have knee pain. Their arthritis isn't that bad. They still have some joint space left in there, but everything else we've been trying just hasn't worked or has stopped working essentially. And so I try and have a really frank discussion with these people that, your joint doesn't look that bad yet. I understand you're having a lot of pain, but if we can try and put this off a little bit longer until, your arthritis gets worse or you're getting closer to being bone on bone, the people that I think we pull the trigger too soon on just generally are not quite as happy. Um, I think it's just setting expectations because, you know, I always tell people, like, particularly for knee replacement, this is not going to be your 18-year-old knee. I can't guarantee you that it's going to be pain free. It Most of the time it is. Most of the time you'll get back to doing all your normal activities. But like as we age, it's not just the joint, but like your muscles and tendons, you get weaker, and that contributes to just painful joints. Your bone just isn't as good. It's just hard. Your flexibility isn't as good. It's just harder to do things like get down on the ground and get up from the ground and kneel down and do all those types of things that was way easier to do when you were younger. So I tell them it's like I said, it's not going to be your 18-year-old knee, but it'll certainly be better than what it was once it becomes very arthritic.
Yeah, absolutely. And then what's you kind of touched on it, but what's that exact moment when conservative treatment has run its course?
When somebody comes in and you can tell pretty quickly, especially if I've been seeing them a couple times and treating them for, say, knee arthritis. We've gone through some injections. They've tried some anti-inflammatories. They've done physical therapy. You can usually see that on their face. They just look tired. They're worn out. They're sick of dealing
Yeah.
with it. And I always ask them, like,
Yep.
how much is it affecting your quality of life? Because sometimes I'll have patients that say, well, my knee looks really bad. I should probably just get it done now. I'm like, we really don't do this until you're having the pain with it. Like we're not just treating the joint. I mean, we're treating your quality of life. And so if your quality of life's diminished, and that's something you can read on somebody's face generally pretty easily after you got to know them a couple times, it makes itself pretty apparent. And I can tell when some people walk in and they're just done dealing with it. They know it's
Yeah, they
time.
have that beat down, run down kind of
Yep.
look on
Yep.
when it starts
And
to affect their sleep, not just walking around or
absolutely.
stairs or things like that, but they can't sleep and that affects everything.
Yep, absolutely. I have that question on my intake form when I have patients come in and how much is it affecting your sleep? How much is it affecting your quality of life? Are you not doing your normal activities as much or at all as you would want to be? So it's a quality of life thing, not so much, like I said, I've seen really bad knees before, but those people aren't really having a lot of pain sometimes. So I
Yeah.
say you
Yeah.
just continue to do what you do until you do have pain, and then we can have the discussion.
Perfect. Yeah. And this is a perfect segue as well. So how much does an MRI or an X-ray influence your decision compared to what the patient is actually telling you?
Um, the X, I put most of my decision making in what the patient's telling me. I think if sometimes I feel like as physicians, we've gotten away from, this subjective talking to the patient and just feeling out what their whole situation is because everyone's in a little bit different situation
Yeah.
or, and then we just look at the x-ray and show them the x-ray and, like I said, somebody can have a really bad x-ray, but, they're not having that much pain. I don't think that person's going to be doing great with a knee replacement right away. Now, eventually, maybe, but and when it comes to MRIs, I will occasionally order an MRI. I think there are some instances where the X-ray just it doesn't look that bad, but what the patient's telling me, and the fact that none of our conservative treatment has helped a whole lot, would indicate to me that the joint might be worse than it looks on the X-ray. Sometimes people can have like labral tears around the hip, degenerative meniscal tears, strains of the ligament, focal like cartilage lesions in the knee that we don't really see very well on X-ray. And so all that stuff shows up better on an MRI. So in some instances, I will use that to help make the decision. But oftentimes, I don't need an MRI to tell the patient that they're going to they would or would not benefit from joint replacement.
Sure, sure. Yeah, you see that worn out joint and the joint space is narrowed
Yep.
and it's matching up clinically, then yeah. So now hip versus knee replacement, which operation has changed the most over the last decade?
Well, I think both have changed significantly in the fact that we use a what we call polyethylene plastic. It's like a little plastic piece on the knee that inserts in, and that gives you a nice smooth surface. And then on the hip replacement side, there's a cup that we put in with that polyethylene plastic. We've found new ways to develop that, in the last 15, 20 years that it's not wearing out like it used to. And so telling people now, if everything goes well, you can expect this to last 25 to 30 years. Honestly, it might be longer than that. So that's one of the biggest changes that has come in terms of the technology of joint replacement. One of the other things is, I think as our field progresses, we're doing more and more patient reported outcome research to see how patients are doing afterwards and how much it's helped them. And I think that's helped drive some new areas that we're looking into in terms of like patient specific alignment with knee replacement. And this kind of starts to go into the whole robotic discussion potentially. I think at this point, robotic joint replacement, I think when compared to like a high volume hip and knee surgeon, there's not any difference in the patient reported outcomes. At least there hasn't been shown to be. So somebody that uses a robot versus somebody that's doing a lot of these all the time, those patients have very similar outcomes. There's a whole discussion to have on robots. I think in the future that there's certainly a role for it. I just don't know that we know like that exact role yet because we just don't know, for example, on the knee replacement side of things, if as we look in more into individualized alignment, we just don't know what basically the goalpost is, like what we're trying to get to. What is that? What alignment does that particular person need that's going to give them the best result? We can't say yet.
Okay.
I mean, that's something we're looking at, and we're kind of starting to tailor things that way. We just don't know for sure. And that's where the robots will eventually come in and be helpful, I think, is when we do know that exact goalpost of what we're trying to get, the robot can help us get there. But for the time being, I don't think there's any difference at this point.
Interesting. Okay. Now, one thing I'm hearing more and more about, I'm guessing this is trademarked, but the Jiffy knee.
Yep.
And so, yeah, can you kind of tell me like what's, your standard total knee replacement versus the Jiffy knee? Like what's the difference? What are the benefits, pros, cons, things like that?
Yeah. I did not train with anybody that did the Jiffy knee. And, you hear all these things about minimally invasive, and that is what the Jiffy knee is what we call basically a subvastus approach. So it's the incision into the joint capsule stays below the vastus muscle. So it does not cut into the quad tendon.
Okay.
And so what we found is that when you don't cut into the quad tendon, there might be a little bit faster recovery in the front end of things than maybe the first couple weeks. And most of that comes with maybe pain a little bit, maybe function of the quadriceps, like if the quadriceps is just stronger and you're not trying to repair that incision that we had to put into the quadriceps tendon. Certainly, I think there's some good data to show, like I said, that it might be beneficial in the first couple weeks, but what I do know is all the data in long term shows that everything ends up being equal.
Okay.
So I do think there's a little bit of marketing push behind such thing as a Jiffy knee.
Yeah.
I don't do that subvastus approach yet. I've been considering attempting it and looking into it just because I am curious if it will get my patients back to moving their knee faster, better, and with less pain. But I'm not convinced yet that I need to change my whole practice because I think my knee patients do
Yeah.
pretty well as it is, but it's something it's worth looking into.
Well, along those similar lines, I guess, let's talk about, anterior versus posterior hip and,
Mhm.
how you approach one versus the other and maybe what the recovery looks like as well.
Yep. So I actually, in residency, I trained with some people that did an anterior hip approach. And then in fellowship, I actually trained with some people that mostly did posterior approach. I honestly think that, and most of the data will probably show this too, that again, in the long run, everything kind of ends up being equal between the two. Really, what you should have done is whatever surgeon you're going to see, it feels most comfortable using. And sometimes that's the posterior approach. It's probably getting phased out a little bit just because of how this big push to anterior. But I do think in the first couple weeks, there's probably a difference for some patients, not everybody, that the anterior approach, gets you up on your feet, moving a little bit quicker. There's probably not as much loss of strength, and it's just a little bit easier of a recovery, is what I've seen in my own practice. But, I think either approach is good. It's just the anterior approach allows me to make a little bit smaller incision. I think there's a slightly less risk of dislocation. Now, that being said, I think most people who use posterior approach have also a very small dislocation risk or rate. So that's not that different. Like they're both less than 1%. So extremely rare.
Okay. Yeah.
But those are kind of the big things between anterior and posterior approach. And so
Gotcha.
I do anterior approach for all my first time joint replacements. And I use a bikini incision. I used to use the longitudinal incision. I just had a couple wound issues with that in the course of a couple weeks. And I had trained with somebody that did the bikini incision. And the bikini incision is just this, it's in line with your natural skin line. So I found it just heals a little bit easier. I was not worrying nearly as much about the incisions and the wound healing issues as I was when I used the other incision. Neither one's right or wrong. It's just kind of practice dependent is my guess.
Yeah. Okay. What are your thoughts on rehab after a total hip? Because we've seen it where, we'll get some patients right after a total hip. We'll get some where physical therapy is not recommended, or maybe we'll see them like months down the line as well. So I
Yep.
just want to get your thoughts on that.
When it comes to hip replacement, I truly think it's probably patient dependent. I always tell people I never really send hips to physical therapy. Most of your therapy is going to be getting up and walking, but that's not everybody. If their joint's really bad and they're really stiff and like basically they've lost all cartilage and they're like all nearing fusion of their hip when I see them, they're going to be somebody that's probably benefit from physical therapy. Additionally, somebody that's maybe a little bit older, a little bit weaker, they'll probably benefit from some therapy. And so I rarely send somebody in the first couple weeks. And then when I see them in clinic, I can kind of make a determination of, yeah, I think you might benefit from some therapy. I think you'll recover a
Sure.
little bit quicker if we get you moving
Yeah.
and strengthening. But like I said, with the anterior approach and some of my younger patients, really, I just tell them to get up and walk, and they're off of the walker in a couple days, onto a cane, off that pretty quick too. And I don't feel
Yeah.
like they need
It is really
therapy.
amazing how, people can get up, you'd replace their entire hip joint, like, but they can
Yep,
get right up right after surgery and walk around. It is amazing how
yep,
quick people can recover from it.
yep, absolutely. And like I said, I think it's patient dependent too. I always tell the people the best predictor of like your motion and strength after surgery and how you recover is going to be like the strength that you have going in. And I know for some people with a bad joint, that's hard because as time goes on, the joint gets worse. They probably lose strength. They obviously lose mobility. And so the longer they've had that bad joint, the more likely they might need some therapy afterwards to kind of get things moving properly again, get the muscles functioning.
Sure. One thing too, and I'd be curious to get your thoughts on this. And this is, I guess, more anecdotal from what we've seen, though. We've been doing, over the last year or two, really, we've done a lot of like balance and fall risk
Hmm.
prevention. And so it seems like we get people who have had a total hip but didn't have rehab right afterwards, who do
Hmm.
fine for several years. And then you get out several years, and now they're having balance issues, and that operated side is much weaker than the other side. And so
Hmm.
that's something I've started asking people, just because it seems like they don't put two and two together because the surgery was so long ago. And it's like, well, you had this major surgery. They cut through some muscles. You didn't rehab. You walked, which is
Hmm.
fine. Maybe they're working out in the gym, but now we've got all these balance issues, and that hip is really weak. And so I don't know. I'd be curious to just see if you're
Yeah,
seeing anything like that, or what your thoughts are about it.
I feel like
And
I
maybe
have
it's
seen a
maybe
little
it's
bit of
just a
that.
coincidence too. But
Yeah, I feel like I
yeah,
have seen a little bit of that. And, that might be something that now that I think of it, there might be something to that where having a posterior approach that does kind of cut into the gluteus and
yeah,
you're kind of messing around with the abductors a little bit more. I think I've seen some patients that have gotten, 5+ years out from that and they
yeah,
just have a little bit of weakness. Now, I don't think it's weakness that's permanent necessarily, but
right,
because in the anterior approach, when we don't really cut through any muscle, we just kind of go between them more or less.
yeah, yeah,
So I don't know. I mean, I think that's a good point. It's an interesting thought that it's something to kind of pay attention to for me at least. That
sure,
seeing
yeah.
people ways out if they're starting to have balance issues and their operative side is a little bit weaker. could be that you're right. They never should never rehabbed properly.
Right, right. And some people too, I like kind of you said with other things, it's patient dependent, you know. Some of those people just aren't very active to begin with. And
Yeah.
so, you know, maybe they're getting a total joint, but they're sitting in a chair most of the day. So that's
Yeah, exactly. And I try and encourage all my patients to be active. I mean, I think, like I was saying earlier about, motion is lotion. Like it's still going to be that way when you have a joint replacement too. Yeah, the arthritis isn't going to come back, but if you don't use that joint, it's just going to get weak and probably become painful and probably stiff. So you got to use it.
yeah. Yeah, let's talk about the total knees now too, the recovery process for that. You know, that's a little bit different from what a hip looks like. And so, I guess just gonna kind of give us your philosophy on rehab after a total knee.
Yeah, I feel like it's ever changing a little bit. When I was in residency, I think the push was start physical therapy as soon as possible, and we got to get the motion back or else you're going to lose it. And I think we were probably doing a little bit of a disservice to some people because we were starting to crank on their knees a little sooner than we probably should have. You know, tell a lot of my patients now, I start them with the CPM machine. I don't know that there's a lot of good data to support that, but I know patients like it. They just feel like it's starting to move the joint. And I tell them you can't rely on that. It's nice to start moving the joint early, but you really got to start firing those muscles when you're ready. And the question is like, when is somebody ready? There's this whole quiet knee protocol that's kind of come out recently, and I don't know that I'm following it to a T, but I'm starting to kind of implement it a little bit in my practice. So I tell a lot of my patients, it's extremely important the first week that you ice and elevate and you just take it easy. I want like less than 700 steps a day. Yeah, you can move it a little bit, but your bigger goal right now is to get the swelling to go down, the inflammation to kind of start to resolve a little bit. And then I think if you're able to achieve that, then getting people into therapy, they just do better sooner. They're not trying to push through pain necessarily. Yeah, some the therapy will be discomforting, but I think I've seen patients that have pushed it too hard with therapy a little bit early on and then have just
Yeah,
been a little bit of a slower recovery. So I think therapy is vital for knee replacements. Maybe some of my patients can do it on their own, not many, but I think that just maybe starting it a little bit later and getting them a little bit better spot in terms of the swelling and inflammation afterwards, it kind of helps set them up for success a little bit in terms of getting their motion back. 'Cause I've been pretty happy
yeah.
with, a lot of my patients having near full range of motion about 6 weeks out. So
Yeah, I think I'd agree with that too, because if you're, you know, if that joint's swollen, it's inflamed, we've got pain, and you're just fighting against it, then you're not really getting rid of that inflammation. It's just staying there, and it's like this cyclical process where you need to get your motion back, but it hurts and it's swollen, and now we're cranking on it, and
yeah,
it's not helping any. So yeah, I kind of like the
absolutely.
idea of just letting it all calm down for a little bit, and then let's get in there and let's get some work
Yeah,
done.
I think like the quiet knee protocol, I think it's really they don't start therapy until like 2 weeks or something.
Okay,
I want to move it in a little bit earlier than that, I think, but there's some good data that shows, people still get motion back if they wait 3-4 weeks to start therapy.
sure.
And so I
I'm glad
just
you mentioned the CPM. It's something I always ask surgeons just because I'm curious. Everyone has a different take on it, but it seems like a lot of surgeons here still use them, and they all say the same thing that you say. It's like, there's not a lot of data to support it, but people like it, and the
yeah, I
outcomes are good.
mean,
So let's keep.
yeah, like I've had a lot of patients come in and say, I had so and so do my other knee replacement and they didn't use a CPM, but I really like it. I'm like, and
Yeah,
I give everybody the option to use it, but I also make sure I specify that like this does not replace your therapy. This is just something to help with a little bit
sure.
early on.
Right,
So
right. Start getting
yeah,
some motion back in there.
yeah.
Yep. What are your thoughts on prehab and getting people in? Strengthening it up, getting that range of motion as good as you can before they go in for a total joint.
I think, I probably don't send as many people to doing like prehab as I should. I try to have the conversation with them about it most of the time because I do think that it makes a difference. Like the strength that you have going into surgery is just going to make the recovery that much easier. You're just going to have better muscle mass. It's just your quad probably won't shut down nearly as much. If you have a weak quad going into knee replacement, it's going to be a tough recovery to get that quad to wake up and then strong enough to support that knee and start getting full extension. So I think there's definitely a role for prehab.
I always tell people the same thing, if your strength and motion is here, like you're gonna lose it after surgery regardless.
Yep.
So if we can get it up here and it drops, well, we're already above where you were
E-
before. It does make a
exactly.
difference. So
Yeah. The
yeah,
surgery will certainly be a hit to it. And so if you're able to increase it beforehand, I think that's helpful.
yeah, absolutely. What would you say is something that patients obsess over during recovery that really doesn't matter?
Swelling, probably. I think there's a level of swelling that to be concerned about sometimes.
Sure. Yeah.
And everyone's different. Everyone's tissue is going to react differently. Some people are just more prone to swelling, and it's particularly with knees. But I still have patients coming at 3 months out. They're like, "Yeah, it's great. I'm up and doing everything I want to do, feeling good, but I still get swelling in my knee." I'm like, "That's something that's probably going to be there, maybe a little bit forever, because you did have surgery on that leg. But it can persist for up to a year afterwards, certainly."
Yeah.
Now I think
Yep.
it'll certainly get better in the coming months here, and so it's just kind of interesting that people are doing so well and they're like, but I still have all this swelling. I'm like, it's not that bad. It's certainly
Yeah.
there. Yes, that knee is still a little bit bigger than the other one,
Yeah.
but that's probably the one main thing. I
Yeah.
always
I
ask
just
them
like
like,
that aesthetic piece that you talked about
yeah,
earlier.
yeah, I'm like, well, I understand you're having a little swelling, but you're having pain or
Right.
people sometimes complain about like swelling or often like with knee replacement, like a little bit of clicking, like I feel like it'll pop or click a little bit. I was telling them it's
Sure.
like it is metal and plastic in there. It's pretty normal. Typically, as you develop more scar tissue in there, that'll happen less or be less noticeable. But I always say if you're not having pain, it's a good sign. So
And on the flip side of that, then what's something that patients ignore that absolutely determines their outcome?
I think when it comes to knee replacement, probably working on the strength in the quad, getting that built back up strong.
Yeah.
We care about motion a lot because we need you to get to a functional range of motion. But I feel like sometimes
Yeah.
people get the motion back. They're like, all right, I'm good. I'm done with PT. I'm like, I would
Yeah.
still like you to do the exercises at home at least and keep working on strengthening that leg. So I often do not resurface the patella or the kneecap unless it's truly a lot of arthritis under it. I just think it's hard to reproduce the exact thickness and the mechanics of the tracking of the kneecap if you resurface it every time. And so and for people to do well with that, I feel like they need to build up particularly the vastus medialis of the quad to really help with that patella tracking. Because I have had some people that have come back and said, well, my kneecap hurts. You didn't resurface it. Like, we talked about maybe you would, maybe you wouldn't. I kind of make the call at the time of surgery. And oftentimes I'm about 80% not resurfacing. And I found that after I had a discussion with these people, if we get back into some therapy or they work on building that vastus medialis muscle up, and they're able to do things like stairs get easier. They're able to get up from a seated position without having to use their arms. And so I think they're always like, well, do I need to go back and have it resurfaced? And like, no, let's work on some strengthening. I think you're just a little weak still.
Yeah.
And
Sure.
a large majority of the time, those people will come back and say, yeah, everything's better.
Yeah. If someone wants the fastest recovery possible, what are the biggest predictors?
Uh, s- Strength going into it. The first couple of weeks, like I said, taking it easy, not pushing things too hard. I think like the first 3 days are vital in terms of, icing, elevating as much as you can. And when I say elevating, like hip or knee, try to get above the heart level. It's harder with your hip, obviously, but your knee, you can lay down on the couch and prop that thing up and help with the swelling and the inflammation. I think those are vitally important. I think it kind of sets the stage for the whole recovery. And then just protecting the incision. I use two different kind of dressings over it that are kind of both adhesive, and you can shower with both of them. But I think just protecting that, making sure it stays clean and dry, and that bandages not peeling off. Because the last thing you'd want is like a wound complication. That's always like our biggest fear. Because then you get into the realm of, am I worried about infection or is the wound breaking down? That's all concerning stuff.
Yeah. So how much of recovery is actually surgery versus the patients putting in work afterwards?
I always tell people it's a two-way street. I do my job on the day of surgery, but you have to do your job in the recovery process. And unfortunately, your job is going to last longer than mine. I tell people for both hip and knee, it's going to be a 3-month recovery. Now, the first 6 weeks are going to be harder. that back half 6 weeks, things get easier. You get back to doing more your normal things. But
Yeah,
certainly, I try and set the stage for them that they need to be putting some effort in, because they're if they don't, say their knee gets stiff or they don't get all their strength back. I mean, like, you're not going to like it. It's not going to function the way you want it to. It'll still be sore and painful potentially. It'll be stiff, and it's not going to work out well.
sure. Yep. Is there anything that we haven't talked about that you want people to know?
I don't know. I feel like we certainly covered quite a bit. I think the big thing is try and exhaust all conservative treatment options when you start to develop painful joints. I think because what we do have, it works pretty well. You know, physical therapy, bracing, anti-inflammatories, injections, those are all pretty tried and true. And then, once it gets to the point where it's none of that's working anymore, it might be a time to have a discussion about surgery.
Awesome. If people want to learn more about you or if they want to find you, how can they do so?
On the Des Moines Orthopedic Surgeons website, my bio on there, which I think you read from a little bit earlier, a little bit about
I
me.
did. Yep.
And then, yeah, that's probably the best place to find me. I think.
Perfect. Awesome. Well, Dr. Dixon, thank you so much for taking time out of your busy schedule. I really appreciate it.
Yeah, absolutely. I appreciate you having me on. It was great talking to you.
Thank you.